In this lecture, we'll talk about allergic rhinitis. And allergic rhinitis is a medical condition that is characterized by inflammation of the nasal mucosa due to the inhalation of an allergen. It's a pretty common disease and it affects about 10 to 30% of the population. And it is commonly diagnosed at younger age. So, about 80% of people with allergic rhinitis are diagnosed before the age of 20. And it seems like allergic rhinitis has a genetic predisposition. So children have 30% chance of developing allergic rhinitis if one of their parents has allergic rhinitis. And if both parents have allergic rhinitis, there is 50% chance that the child will have allergic rhinitis. In this lecture, we will talk mainly about allergic rhinitis, but in the first couple of slides, we will just have a brief discussion of non-allergic rhinitis for the sake of differentiation and making sure that we are able to exclude those with non-allergic rhinitis. So here's the first question. All of the following are symptoms of allergic rhinitis except, and the answer for this question is F. Actually, all of these are symptoms of allergic rhinitis. So you may just wonder what some of these are, like what is Dennis Morgan lines, what is the allergic shiners. So we'll have the visuals for these on the next slide. So this is what we call the allergic shiners. Allergic shiners are dark areas around the eye, especially the lower lid, as you can see, and it is believed to be due to improved circulation. There is more blood circulation in the area that's causing this kind of dark spots. Um, in terms of Dennis Morgan lines, you can see these lines here. It's like a skin fold under the lower lid of the eye. And the transverse nasal crease is what you can see in this slide. This is, I believe, due to the patient, they keep rubbing their nose. On a later slide, we will classify allergic rhinitis into intermittent and persistent, and this is when we talk about the treatment of allergic rhinitis. There is another approach that can be used to classify allergic rhinitis, which is seasonal allergic rhinitis and perennial allergic rhinitis. Seasonal is when the patient has symptoms during one specific time in the year or multiple like seasons, like and in between the patient is symptom free. So, for example, the patient may develop allergic rhinitis symptoms during the spring, but in the winter and in the summer, the patient may not have symptoms. Perennial is when the patient has symptoms year round. We can also guess the kind of allergic rhinitis the patient has based on the allergen. So, if the patient, for example, has allergy to pollens, typically this happens in the spring and summer, but not in the winter. If the patient has allergy to dust mite or animal dandruff, or if the patient has allergy to cats, for example, in this case, this is perennial allergic rhinitis because this can happen year round. So it is not limited to a specific season. This is just for your information, the seasonal perennial classification. However, we use more the intermittent persistent as an approach for the management of allergic rhinitis, as we'll see. When should we refer the patient with allergic rhinitis to the physician? So, in viral rhinitis, common cold, we mentioned that there is some overlap in the symptoms between viral rhinitis and allergic rhinitis. And we mentioned some red flags in viral rhinitis, like fever, like neck stiffness, like wheezing, chest. And these are also red flags if the patient has these symptoms along with allergic rhinitis. But here on this slide, we'll discuss red flags that are specific to allergic rhinitis. So we will refer children less than 2 years of age, regardless of the severity of their symptoms. Also, if the patient tries an over-the-counter antihistamine for 2 weeks without effect, the patient should be referred to the physician. Please make sure you remember this. So, if a patient comes to the pharmacy, you recommend loratadine. The patient takes loratadine properly, and the patient comes after 2 weeks with no effect. This patient should be referred to the physician. Also, symptoms suggesting complications like what? Like otitis media, worsening asthma, or sinusitis. When we mention sinusitis, it's important to please remember that green nasal discharge indicates inflammation, does not indicate fever. So the fact that a patient has allergic rhinitis, and along with the allergic rhinitis, the patient comes to the pharmacy complaining of uh, green nasal discharge, this does not indicate that the patient has infection. We will only refer the patient with green discharge to the physician if the patient had other symptoms suggesting infection, such as fever, for example, or maybe sinus pain or something like that. But green discharge alone is not enough to refer the patient to the physician. Also, patients with moderate to severe allergic rhinitis, they have to be referred to the physician, or those who have mild allergic rhinitis, but the symptoms last for more than 2 months. They also have to be referred to the physician, even if they are taking like an antihistamine and the antihistamine is effective, that's fine. So they have mild symptoms, you give them an antihistamine, the antihistamine works fine, but they need it for more than 2 months, they will have to be referred to the physician. Also, patients with unilateral symptoms, allergic rhinitis is bilateral. So if the patient has symptoms in only one nostril and not the other, this patient should be referred to the physician. And finally, if the allergen is not identified, because in this case, the patient will require referral to the physician for allergy testing. So generally speaking, rhinitis can be classified into three categories. The first category is allergic rhinitis. That's when the immune system is involved in the development of the symptoms and there's production of immunoglobulin E and so on. The second category or the second class of rhinitis is what we call non-allergic rhinitis. That's when the patient has symptoms that look like rhinitis, but the immune system is not involved in the development of these symptoms. And the third category is what we call drug-induced rhinitis, and some references will include drugs-induced rhinitis in the non-allergic rhinitis, and that's what we have done here. So here we'll talk about the causes of non-allergic rhinitis. So patients with upper respiratory tract infection, they may have symptoms of rhinitis. They will have runny nose and stuffy nose, but they don't have allergic rhinitis. The immune system is not involved. Alcohol drinking can also induce rhinitis. Pregnancy and during menstruation, the female may experience rhinitis. We have an important category that's also known as vasomotor rhinitis. This is one of the non-allergic rhinitis. Vasomotor rhinitis is due to vasodilation of the nasal capillaries. And usually patients who have vasomotor rhinitis, they produce a significant amount of nasal discharge. They have very, very watery nose or runny nose. Causes for vasomotor rhinitis include exposure to cold or dry air, eating hot or spicy food, excessive exercise, exposure to bright light, and intense emotions such as stress or sexual dysfunction, and finally, secondhand smoking or exposure to smoke. Hypothyroidism also can cause non-allergic rhinitis. In terms of medications, as you can see here, we have several medications that can increase or cause non-allergic rhinitis. This includes beta blockers, aspirin, ACE inhibitors, hydralazine, diuretics, NSAIDs, sympatholytic drugs such as alpha-1 and alpha-2 blockers, gabapentin, cocaine, antipsychotics, phosphodiesterase type 5 inhibitors, and oral contraceptives. There are two categories of drugs or two classes of drugs that can cause what we call rhinitis medicamentosa. That's when the patient has stuffy nose and runny nose due to the medication overuse. And this includes the excessive use or prolonged use of topical decongestants and prolonged use of sympathomimetic drugs such as amphetamines. So how do we manage drug-induced rhinitis when the patient has rhinitis due to a drug that the patient takes? The first thing we do is we stop the offending drug, and this is if we can. Um, and then if we need to give medications, we start intranasal corticosteroids, and they are considered the first choice in this case. We may add to the intranasal corticosteroid a decongestant, we may or may not, and the decongestant can be oral decongestant or topical decongestant, and as you know, the topical decongestant should not be used for more than 3 days. If the case is resistant, we add oral steroid to the intranasal corticosteroid, so the patient will be taking two. The oral steroid will be used for 7 to 10 days just to give us a kickstart. And after 7 to 10 days, we will stop the oral steroid and we will continue with the intranasal corticosteroid. How do we manage rhinitis medicamentosa? This is the stuffiness of the nose or nasal congestion secondary to prolonged use of topical decongestants or sympathomimetic drugs such as amphetamine. The first choice we have is to use intranasal corticosteroid, and fluticasone spray was found to be effective in rhinitis medicamentosa. It starts working and reversing the congestion in about 3 days, but it may take longer for the patient to feel significant improvement. Another approach we have for the management of rhinitis medicamentosa is cold turkey. The patient just stops using the topical decongestant. Of course, the patient will have significant stuffy nose because the patient is no longer using the topical decongestant, and it's within few days, within a couple of weeks, the nostrils will be clear. Of course, there is some discomfort because of the stuffiness that the patient will experience, but it is one strategy to just stop the topical decongestant cold turkey. The third strategy we have is to use the topical decongestant in one nostril only. So the patient, let's say, will apply the topical decongestant only to the left nostril, let's say, only in the left nostril. So the right nostril will be congested, and the patient will be mainly breathing through the left nostrils where the patient applies the topical decongestant. The right nostril that the patient does not apply the topical decongestant in will be stuffy, and it may take maybe 1 or 2 weeks till it clears. Once it clears and the patient can breathe through the right nostril, then the patient will stop the topical decongestant from the left nostril. So we will open one nostril at a time. This is what we mean by alternating nostrils. Treatment of allergic rhinitis. We'll start first by discussing the non-drug measures for management of allergic rhinitis. And it's very important for patients who have allergic rhinitis to identify what triggers their symptoms. And once we identify these triggers, the patient should avoid them. And for a good discussion about the different triggers and how to avoid them, I will refer you to the asthma chapter. You have a very good discussion of the different triggers of asthma, which also can trigger allergic rhinitis, like pollen and house dust mites, and how to avoid these triggers. Patients with allergic rhinitis also should avoid first and second hand smoking, and they also should use nasal irrigation. Nasal irrigation and how it's done is described in details in rhinosinusitis under infectious diseases. And typically, nasal irrigation is done using saline solution. That's when we gently force the saline solution through one nostril and it circulates in the sinuses and it comes out from the other nostril. And this way, the saline solution will flush any allergens or pollens that got stuck in the patient's nose. Nasal irrigation in allergic rhinitis reduces symptoms because you keep flushing these allergens from the nose. So it reduces symptoms and it reduces the need for therapy in both adults and children. And usually, when we do nasal irrigation using saline solution, we typically use isotonic saline solution like the 0.9 percent. And sometimes we may also use the hypertonic because the hypertonic can also reduce the edema in the nasal mucosa. Now we'll talk about the drug management of allergic rhinitis. So all patients with allergic rhinitis must try allergy avoidance first. And we don't start therapy unless allergy avoidance is not effective or it's impractical. So for example, the patient has a cat and the patient has allergy to the cat, but the patient refuses to get rid of the cat. So this means that allergy avoidance in this case is impractical. Now, when we treat allergic rhinitis, we have two approaches for the treatment. The first approach, which is the most commonly used one, is the one that depends on the severity and the frequency of symptoms. And this is the one we'll discuss first. And the second one will depend on the duration of the symptoms. We have both on the same table, but we'll start with the commonly used approach first, which depends on the severity and the frequency of symptoms. So the first group of patients are patients who have mild or infrequent symptoms. So these are patients who have symptoms that don't interfere with their daily life. Yes, they do have allergic rhinitis, but they are able to work, they are able to go to school, they have no problem with their daily activities. For these patients, we will give them nasal saline spray with or without second generation antihistamine regularly. And the word regularly here is very important. When we use antihistamines for patients with mild or infrequent allergic rhinitis, we recommend the antihistamine regularly, not as needed. So if you have a patient who comes to the pharmacy and um, the patient has been using loratadine as needed for allergic rhinitis, and the patient comes saying that loratadine is not effective for my allergic rhinitis, one reason is because you have been using loratadine as needed, and it should be used regularly. And as we mentioned before, we can use it for 2 weeks. If it's not effective after 2 weeks of being used properly, then we will refer the patient to the physician. But before we refer, we need to make sure that the patient takes the drug properly. So we give nasal saline spray with or without second generation antihistamine regularly, with or without decongestant PRN for stuffiness. If this treatment is effective, then we will continue while exposed. Whenever the patient gets the symptoms, the patient will keep using the treatment for the duration of the symptoms and while the patient is exposed to the allergen. If this approach is not effective, then we will treat the patient as under moderate to severe. The next group of patients we'll discuss are patients who have moderate to severe symptoms of allergic rhinitis. And first, we need to define what is moderate and what is severe. So, moderate symptoms of allergic rhinitis are symptoms that affect sleep and also affect activities, but the patient can still function. The patient is still able to go to work, etc. There is difficulty, but the patient can function. Severe symptoms are symptoms that reduce daily activities. The patient may not be able to function, and or the patient may have lack of sleep. Lack of sleep, not just affect sleep. No, lack of sleep. The patient can't sleep at night because of the symptoms of allergic rhinitis. For patients with moderate to severe symptoms, we will give them intranasal corticosteroid regularly. And the word regularly again is very important because this tells you that it will be used daily, not PRN. So we'll use the intranasal corticosteroid once or twice daily, not PRN. And something generally about corticosteroids you will notice is corticosteroids in any allergic conditions, like for example in asthma, in allergic rhinitis, we don't use steroids in general, PRN. We need to use them for duration of time in order for them to be effective. So the drug of first choice in the moderate to severe symptoms of allergic rhinitis is intranasal corticosteroids regularly, once or twice daily. And then, depending on the patient's symptoms, we may consider adding other medications as needed. Like what? Like antihistamine. Please note, as needed here refers to the use of these medications. It doesn't refer to the dosing. So, as needed here means add the antihistamine if you need the antihistamine. But once you use the antihistamine, it will be used regularly. So PRN doesn't refer to the dose of the antihistamine, it refers to the use of the antihistamine. So to the intranasal corticosteroids, we will add an antihistamine if we need an antihistamine, and it will be used regularly. Sometimes we do that because intranasal corticosteroids, and generally some, like all corticosteroids except the systemic ones, may have some delayed effect. So we may need an antihistamine for bridging therapy to give some relief until the intranasal corticosteroid is effective. We may also consider adding decongestant if the patient has a stuffy nose, leukotriene receptor antagonist, ophthalmic antihistamine if the patient has more of ocular symptoms, or mast cell stabilizer. Or we can consider using intranasal corticosteroid plus intranasal antihistamine. If the treatment we will use either intranasal steroid plus the PRN medications or intranasal steroid plus intranasal antihistamine, if it's effective, then we will continue this regimen while the patient is exposed to the allergen. If it's not effective, then we will add prednisone, like oral prednisone, for 5 to 7 days. This is just to kind of quickly clear the allergy symptoms, and then we continue with the intranasal corticosteroids as maintenance. So the cortisone, the prednisone, is added to the intranasal corticosteroid. So the patient will use the topical and the systemic together, and then we maintain with the intranasal corticosteroids. If the patient continues to have ongoing symptoms, then in this case, we may consider immunotherapy, as we'll discuss in a few minutes. Now we'll move to the second approach in managing allergic rhinitis, and this approach depends on the severity as well as the duration of symptoms. This is the approach that's described in the minor ailments. So you may ask, which one should I use if I get a case in the exam? I would go more with the most commonly used approach, which is the approach that depends on the severity, which is the one we described in the last two slides. But this is just in case if you read this language of intermittent and persistent, so you know exactly what we are talking about. So if the patient has mild allergic rhinitis, and mild allergic rhinitis means the patient has symptoms that are infrequent and they don't interfere with the patient's daily life. Now, for how long does the patient have the symptoms? What is the duration of the symptoms? The symptoms can either be intermittent or persistent. Intermittent is defined as symptoms less than 4 days per week, or the symptoms are for less than 4 weeks of duration. So the patient doesn't have long-term symptoms. The symptoms are short-term, and that's why we call them intermittent. In this case, we use oral or intranasal antihistamine, either daily or PRN. Someone may come and say, oh, we thought that antihistamines will be used only daily. Well, when they are used daily, they are more effective. However, because CTMA is more of a reference for a pharmacist, so they are a little bit sometimes on the conservative side, so they may recommend PRN. But typically speaking, antihistamines are more effective when used daily. And that's why I said I would use the approach that's based on the severity of symptoms rather than the approach that's based on the duration that's described in the CTMA. So for patients who have intermittent symptoms, less than 4 days per week or less than 4 weeks in duration, we use oral or intranasal antihistamine either daily or as needed. If the patient has persistent symptoms, and these are symptoms that last for less than 2 months, basically persistent symptoms are symptoms that are more than 4 weeks. So persistent symptoms here, we have two categories. The first one is less than 2 months. This means more than 4 weeks and less than 2 months. In this case, we can use oral or intranasal antihistamine daily or PRN. That's the same as intermittent. Or we can use intranasal steroids daily. There is another persistent symptom that even has a longer duration when the patient has symptoms that last for more than 2 months. In this case, we will treat the patient as we will see under the next category, which is moderate to severe. For patients with moderate to severe allergic rhinitis, and again, this is when the patient has symptoms that interfere with daily activities and cause troubles sleeping, we will use intranasal steroid. This is the first choice, or intranasal steroid plus intranasal antihistamine. But intranasal steroid as monotherapy is our first choice. And to be honest, in practice, I don't think I have ever seen intranasal antihistamine. After using these treatment options, we will reassess the patient in 1 to 2 weeks. If the regimen we are using is effective, then we will continue along with allergy avoidance as much as we can. And we said all patients with allergic rhinitis should try allergy avoidance. So we'll continue therapy if the regimen is effective. If the regimen is ineffective after 1 to 2 weeks, then we should try an alternative regimen. So if we used initially oral antihistamine, maybe we can now try to use intranasal antihistamine. So we just try to switch therapy to find the one that is most effective. Now we have some final notes about the management approach of allergic rhinitis. So when we treat allergic rhinitis, we start medications with full doses. And we start with the full dose to induce remission quickly. Then later, after we induce remission, we may consider reducing the drug doses to the maintenance dose. So we start medications with full dose, induce remission, and then we may consider reducing the dose to the maintenance dose. Intranasal corticosteroids twice daily are more effective than once daily. Okay, so should we start every patient on twice daily intranasal corticosteroids? No. Typically, intranasal corticosteroids are used once daily. And if the patient uses the intranasal corticosteroids once daily, however, the patient continues to have symptoms, then we consider switching the patient to intranasal corticosteroids twice daily. A very important point here is when we say switch the patient to twice daily intranasal corticosteroids, this does not mean that we will double the dose. No, we will split the once daily dose to make it twice daily. And actually, this is more effective than using the high dose once daily. So if the patient has a prescription for corticosteroids, intranasal corticosteroids, 2 sprays in each nostril once daily. This is typically what you will see, 2 sprays in each nostril once daily. And the patient tries to use this once daily dose of the intranasal corticosteroid, and the patient continues to have symptoms. In this case, we may consider switching the patient to half the dose in the morning and half the dose at night. So the patient will use 1 spray in each nostril in the morning and 1 spray in each nostril at night. Another important point about the management approach of allergic rhinitis is if the patient has predictable allergy. Predictable allergy means the patient will have allergy around the same time every year. In this case, we may consider starting the intranasal corticosteroids 2 to 4 weeks prior to the allergy season. And this way, by using intranasal corticosteroids 2 to 4 weeks before starting the allergy season, we can actually prevent the development of the allergic rhinitis. Of course, the patient will continue to use the intranasal corticosteroids during the allergy season. The patient will not stop. But if we start the intranasal corticosteroids 2 to 4 weeks before the allergy season, this way we can actually prevent the development of the allergy symptoms. Are there any other medications that we can use to prevent predictable allergic rhinitis? Yes, we can also use mast cell stabilizers, and mast cell stabilizers can also start 2 to 4 weeks prior to the allergy season, but no one now uses the mast cell stabilizers. And also we can use antihistamines. So we can use the antihistamines about 4 weeks before the beginning of the allergy season, and this will help to prevent the development of the allergy symptoms. And actually, antihistamines are better to be used for prophylaxis than to be used for treatment. They are more effective in preventing the allergy symptoms rather than in treating allergy symptoms. So in this slide, we try to make a ranking of the different drug classes and their efficacy in different symptoms of allergic rhinitis. So for example, we can start with the runny nose and see when the patient has runny nose, what are the most effective drugs. I don't think this slide is something you will need to spend too much time, memorizing, but it basically tells you what would be the most effective drug if the patient has a specific symptom that's most bothersome. So for runny nose, for example, it suggests that intranasal corticosteroids, intranasal ipratropium, intranasal antihistamines are more effective than oral antihistamines and oral leukotriene receptor antagonists. And there is doubt that mast cell stabilizers will be even effective in runny nose. In terms of stuffy nose, intranasal corticosteroids and intranasal antihistamines. By the way, intranasal antihistamines, the TC suggests they are not effective. Other references suggest they are effective. in stuffy nose. But intranasal corticosteroids, intranasal antihistamines are more effective than decongestants, both systemic or topical, and more effective than oral leukotriene receptor antagonists. Mast cell stabilizers and oral antihistamines, they have questionable effect in stuffy nose. If the patient has itchy nose and sneezing, intranasal corticosteroids and intranasal antihistamines are more effective than the oral antihistamine, and there is questionable efficacy of mast cell stabilizers and leukotriene receptor antagonists. In terms of eye symptoms like tearing and itchy eye, the oral and intranasal antihistamine, intranasal corticosteroids, and leukotriene receptor antagonists, all of them have questionable effect. All of them have questionable effect. So we can try them. We can try and see if they will work. We can give the patient oral or intranasal antihistamine, intranasal corticosteroids, or leukotriene receptor antagonist. Try. If you don't get enough response, then we have to add an ophthalmic antihistamine. We have two of them. We have olaptadine and we have ketotifen. Ketotifen sometimes is classified as antihistamine, sometimes classified as mast cell stabilizer. Why do we add the ophthalmic antihistamine? Because they give the rapid response and their effect usually lasts for 12 hours. Mast cell stabilizers, other mast cell stabilizers that are purely mast cell stabilizers like chromoglycate and nidoquramil and iodoxamide are out of favor. We don't use them. Why? Because they are used 4 times daily and they have delayed response and they are more effective in prevention than the treatment. We mentioned that on a previous slide when we said that when the patient has a known allergy season, when they start to have symptoms, it is better to start intranasal corticosteroids or mast cell stabilizers 2 to 4 weeks before the allergy season. So speaking of intranasal antihistamines, which of the following is not true about levocabastine, which is brand name Levostin nasal spray? Levostin or levocabastine is an intranasal antihistamine. So the answer for this question is D. It's actually used for children 12 years of age and older. It's not used under 12 years of age. It is if there is no effect, if you use levocabastine and there is no effect by day 3, discontinue the therapy. It may not work. You need to shake it well before use because it is available as suspension. It has to be primed before use, like any other nasal spray. And the starting dose is 2 sprays twice daily, and we can increase it to 3 or 4 times daily if needed. So you have this mother here who's going away and she doesn't want to take liquid antihistamine because she's concerned that the bottle can get broken during the trip. What should we recommend for this mother? And the answer for this question is B. So loratadine tablets are tasteless. They don't have any taste, so they can be chewed by the children. There is no problem with that. Nasal saline, which is a choice A, is recommended for children less than 5 years of age, as we mentioned before, just for cleaning and soothing with very mild decongestant effect. Sodium chromoglycate is a mast cell stabilizer, and levocabastine is a nasal antihistamine, and they will not really help in this case much. How do we treat children who have allergic rhinitis? The first thing we should keep in mind is that allergic rhinitis can affect the school performance, and we should treat the allergic rhinitis in children. We should not deal with it as being a trivial condition. If we decide to treat allergic rhinitis, second-generation antihistamines are considered the first choice, and we try to avoid the first-generation antihistamines because they cause sedation, and the sedation may further impair the child learning experience. If the second-generation antihistamine is not effective or the effect is unsatisfactory, we may use intranasal steroids. Intranasal corticosteroids are the most effective therapy in allergic rhinitis. And if we decide to use intranasal corticosteroids in children, mometazone and fluticasone are considered the first choice. Now, children who use intranasal corticosteroids may have two issues. The first one is they may not like spraying liquid in their nose. They may not like the feeling of spraying liquid in their nose. In this case, we may use budesonide powder. It's nasal spray, but instead of being liquid, it is powder. So budesonide powder can be used as alternative. Generally speaking, can be used as alternative, but it's particularly useful in children who don't like spraying liquid in their nose. The second problem we have is some children don't like the smell of the products. Some of the products are scented, so some children don't like the scented product. Here, fluticasone propionate is scented. Fluticasone propionate is scented, but fluticasone furoate and mometazone are not scented. So if the scent is a problem, we may recommend either fluticasone furoate or mometazone. Finally, as we mentioned before, decongestants can be used, but they are only indicated for children 6 years of age and older. Management of allergic rhinitis in pregnancy. We'll start first by listing the options that we can use. So when we manage allergic rhinitis in pregnancy, we can use intranasal corticosteroids. This can be safely used during pregnancy. And as you know from our discussion so far, intranasal corticosteroids are the most effective medications in managing allergic rhinitis. And we can use budesonide and beclomethasone during pregnancy. Antihistamines can also be used during pregnancy, and antihistamines that are especially safe include cetirizine, loratadine, chlorpheniramine, and diphenhydramine, and we also can consider montelukast. If other therapies fail, we can consider intranasal ipratropium or intranasal levocabastine if they are desperately needed. What to avoid during pregnancy? We avoid oral decongestants, especially in the first trimester. They are safe to be used in the second and third trimester, but we should avoid oral decongestants in the first trimester of pregnancy. What if the pregnant lady needs some relief from nasal congestion during pregnancy in the first trimester? In this case, we can use topical decongestants. Topical decongestants are safe to be used. Saline solution may have some mild decongestant effect. However, the safety of saline solution is not established in pregnancy. And we avoid the new second generation antihistamines, ropatadine and blastine. We should avoid these because we don't have lots of evidence about their safety in pregnancy. Finally, we don't start, but we may continue immune therapy. So a pregnant lady or a lady who gets pregnant while on immune therapy for allergic rhinitis, the lady may continue using the immune therapy. But if the lady is pregnant, then we don't start immune therapy. So we don't start the immune therapy during pregnancy, but if the lady is already on immune therapy, we may continue immune therapy during pregnancy. Managing allergic rhinitis in breastfeeding, we use the same approach as in pregnancy, and chromoglycate sodium is no longer available as a nasal spray. We need to monitor the infant for sedation if we use first generation antihistamine or we use cetirizine, because cetirizine is the second generation antihistamine that causes most sedation, and pseudoephedrine is considered compatible in breastfeeding. Next question is about using intranasal corticosteroids. So which of the following is not true about using intranasal corticosteroids? And the answer for this question is D. So fluticasone is indicated in patients as young as 2 years of age. Other nasal steroids are used in less than 12 years of age. So it is common to use nasal steroid. Not all of them, of course, are approved in less than 12, but yes, there are many steroids that can be used in children less than 12 years of age. Fluticasone is an example. It's indicated for children as young as 2. They are more effective, the other choices. Intranasal corticosteroids are more effective than a combination of antihistamine and leukotriene receptor blocker. That is true. Aqueous spray is more effective than the dry powder in patients with excessive stuffy nose. That's also true. And they should be used regularly rather than PRN for better symptomatic relief. And we have mentioned this on a previous slide that they should be used regularly. Next question is about counseling on nasal steroid, on intranasal corticosteroids. So which of the following is not true when counseling the patient on Flunase, which is fluticasone nasal spray? The answer for this question is A. We mentioned that before. Nasal corticosteroids have delayed effect for about 1 week, but actually sometimes it may take 2 to 4 weeks to get some noticeable effect. Yes, some relief in 1 week, but to get some significant relief, it may take 2 to 4 weeks. Certainly, it takes more than 3 days. And it's important because you will need to educate the patient to not judge the drug effect early. So if the patient comes to you after 3 or 4 days and say, the drug that you give me is not working, well, it's too early now to say if it's working or not. All nasal steroids should be shaken gently. So we'll go over the other options. All nasal steroids, all of them, must be shaken before use, basically for one simple reason, that steroids have poor water solubility, so we make them as suspension. So that's why all nasal steroids should be shaken before use. Of course, we're talking about the suspensions. If it's available as dry powder like budesonide, well, you don't need to shake. A spray should be applied pointing upward and angled laterally. So basically, the patient should make sure that they are spraying the nostril, not the nasal septum dividing the nose. The patient usually use the opposite hand to spray the nostril, and this means that the patient holds the bottle in the right hand to spray the left nostril and in the left hand to spray the right nostril. If the nose is stuffy, the patient may use a decongestant for 2 to 3 days. This is just at the beginning, before starting the intranasal corticosteroid as bridging therapy. So when the patient starts intranasal corticosteroids, if they have really bad stuffy nose, well, steroids take time to work. we can use systemic or oral decongestants for a few days just to get some relief till the intranasal corticosteroid starts to work, and that's bridging therapy. Epistaxis, which is nosebleed, it is more common side effect with when Flonase is used routinely for 6 months or more. So if the patient uses the fluticasone for 6 months or more, the patient will start to see more and more epistaxis. That's why it's important to educate the patient to avoid the dryness. Because what happens, why patients develop epistaxis is because of dryness of the nasal mucosa. So we tell the patient to educate the patient to, avoid the dryness. They can use some nasal moisturizer. There is a specific brand name called Sicaris. It's just a nasal gel. It can be used. There is also even very, very small amount of Vaseline on a Q-tip can be used as a moisturizer for the inside of the nose, but very, very small amount. We also have to educate the patient that when they blow their nose, it is normal for them to see little bit of blood when they blow their nose. It is not normal for the patient to be watching TV, for example, and all of a sudden starts bleeding. So in this question, we are talking mainly about those who have a significant volume of nasal discharge. So we usually give intranasal corticosteroids first, but if we try intranasal corticosteroid and they are not effective in reducing the volume of nasal discharge, what will we give next? And the answer for this question is C. So intranasal ipratropium reduces, specifically because it's an anticholinergic drug, reduces the volume of the watery nasal discharge. It is particularly useful in certain cases. First one, in patients with allergic rhinitis who have only, or the main symptom that bothers them is rhinorrhea. So they have just severe rhinorrhea. That's the only symptom that is really bothering them. The second group is patients who have rhinorrhea that persist despite the use of intranasal corticosteroids and or antihistamine. So you give intranasal corticosteroid, it's not helping. You give antihistamine, it's not helping. You can give ipratropium bromide. Also, patients with non-allergic rhinitis, and we did talk about different causes for the non-allergic rhinitis before. Specifically, ipratropium bromide is specifically effective in patients who have what we call vasomotor rhinitis. Patients with non-allergic rhinitis commonly have extensive amount of clear rhinorrhea. They also may have congestion. They have less sneezing, less itchy nose, and less eye symptoms. Their main problem is a significant amount of clear nasal discharge, like clear rhinorrhea with some congestion. So here's the next question. In this case that we are handling, we tried to give everything. We tried to give the patient an antihistamine. It didn't work. We tried to give the patient intranasal corticosteroid. It didn't work. We tried to give the patient ipratropium nasal spray. It didn't work. Now, when everything fails like this, when we don't get significant effect, and the patient continues to have severe symptoms, what should we give the patient? And the answer for this question is C. We start prednisone usually at a dose of 50 milligram orally daily for 1 week. So prednisone is a good choice in this case. Now, for choice D, to consider desensitization, we can consider desensitization, but desensitization is only used when we know exactly which allergen the patient is sensitive to. So desensitization is only effective if we know exactly which antigen the patient is allergic to, and it's not a general approach that can actually be used for everyone. So when all the previous measures fails, intranasal corticosteroids, antihistamine, and anticholinergic nasal spray, adding prednisone 50 milligram daily for 1 week would be a good choice. So the next slide or the next question is about the use of intranasal corticosteroids. So the question is asking, how can we minimize the absorption of the drug, the systemic absorption of the drug following the administration of intranasal corticosteroid? And the answer for this question is A. So applying the spray laterally into the turbinate, not to spray the septum, to spray the turbinate. Actually, it delivers the drug into the turbinate and reduces the systemic absorption of the drug. Also, it increases the effect of the drug and prevent or protect the septum from the atrophy due to the nasal spray. So it's not only that you will deliver the drug to where it works, and this way it will work better, but also you will protect the septum and you will reduce the systemic absorption of the drug. If using multiple spray allow 10 minutes in between, well, this will minimize the loss of the medication, because if you apply one spray after the other, the drug will run off. So in the nose is very little cavity. If you add lots of fluid in it, it would be just running, like runny nose, like the patient will just lose the drug. So if using multiple sprays, allow 10 minutes in between. This is to allow the the drug to get absorbed, kind of thing, into the nasal mucosa. Breathe deeply through the nose after applying the spray. Apparently, of course, this will increase the drug absorption. Tilt the head back after applying the nasal spray. Actually, this will increase the drainage of the medication into the mouth. So the medication will then go to the stomach and get absorbed. So it will not reduce systemic absorption. Finally, we'll talk about allergen immunotherapy. Allergen immunotherapy is like desensitization. It uses the same concept of desensitization. That's when we give the patient a small amount of the allergen so the body kind of gets used to it. The candidates for the allergen immunotherapy are those who have persistent, moderate to severe symptoms that require oral steroids, and those who have unavoidable allergens. For example, a patient has, for example, a cat or something like that, and the patient refuses to get rid of the cat, for example. Or if the patient tries even to avoid the allergen, the symptoms persist. The effect of allergen immunotherapy is to induce remission of symptoms with or without preventing new allergies. And also, allergen immunotherapy was found to reduce the development of asthma in children. Um, Allergen immunotherapy is available as subcutaneous, and it's also available in sublingual formulation. The sublingual formulation of the allergen immunotherapy is available in Canada, and it's used in patients who are allergic to grass, ragweed, and house dust mite.